Pregnancy. Implantation of pregnancy at a site other than endometrial lining in the body of uterus is called ectopic pregnancy. Normally, the implantation of fertilized ovum takes place in the uterine cavity. Any factors that interrupt the successful migration of the conceptus to the endometrium results in ectopic pregnancy. In about 95% of such cases, ectopic gestation occurs in the fallopian tube when it is called as tubal pregnancy. Other cases, it may be extrauterine like ovarian, abdominal in 1 to 2%, which is rare. Uterine, but ectopic location in the uterus can be interstitial, rudimentary horn of the bicornuate uterus, cervical, or at the caesarean section scar. Heterotrophic pregnancy. It is a coexistence of ectopic pregnancy along with an intrauterine pregnancy. Epidemiology. Ectopic pregnancy may occur at a rate of 1 to 80 pregnancies. Significance of ectopic pregnancy lies in the fact that it often goes undiagnosed and patient may have massive intraperitoneal bleeding, risking her life. It constitutes one of the leading causes of pregnancy-related maternal death and accounts for 10% of maternal mortality. The incidence has increased 6 times related to increased incidence of STDs and induced abortions. Increasing incidence of pelvic inflammatory disease in the community, use of IUCD, and wider use of assisted reproductive technology increased the detection and diagnosis due to more sensitive ultrasound technique have contributed significantly to the rising incidence. Etiology. Tubal pregnancy occurs because of the fallopian tube offers the fertilized egg a congenial environment for implantation, or because of the delay in ovum transport across the fallopian tube causes the fertilized egg to implant in the tube itself. The risk factors are previous salpingitis, previous ectopic pregnancy, tubal damage following genital tuberculosis, previous tubal surgery such as tubectomy, tubal reanastomosis in the presence of IUCD, prolonged infertility following ART procedure in infertile women. The commonest causes PID, including sexually transmitted infections such as chlamydia trachomatis and gonorrhea. Other leading causes of salpingitis are septic abortion, post-abortal sepsis, purpural sepsis, commonly seen in developing countries. With the reduction in incidence of gonococcal and chlamydial infection, chlamydial infection predominates and causes extensive and subclinical damage to the fallopian tube than caused by gonococcal. By treating chlamydial infection in women, Swedish study showed a drop in incidence of ectopic pregnancy by 45%. Almost 40% women suffering from ectopic have the incidence of PID. Etiopathogenesis. Congenital defects in the fallopian tube such as accessory ostia, diverticula, partial stenosis and polyp may entrap the fertilized egg and prevent it from reaching the uterine cavity. A cornual fibroid, by narrowing the tubal lumen, can predispose to tubal pregnancy. Transperitoneal migration of the ovum from one ovary to the opposite fallopian tube has been reported on the basis of presence of corpus luteum in one ovary and ectopic pregnancy in the opposite fallopian tube. Delayed transport of fertilized ovum along the tubal lumen may result from impaired ciliary and peristaltic activity in the fallopian tube as a consequence of injury and inflammation. Hormonal contraceptives, especially prostagen-only pills, are known to reduce the tubal motility and thereby favor an ectopic pregnancy. Pelvic adhesions, endometriosis, may distort the tube and cause kinking. Following the surgical procedure of ventrosuspension, kinking at the ischemic portion of the tube may contribute to ectopic pregnancy. Surgical procedures such as tubectomy, by the virtue of spontaneous reanastomosis and tuboplasty, may end up in partial stenosis at the anastomosis site, favoring ectopic pregnancy. Conservative surgery for an ectopic pregnancy is reported to cause repeat tubal pregnancy in 15% of the cases. Laparoscopic cauterization and sterilization operation may lead to the formation of fistulous opening in its medial end of the ligated portion of the tube, permitting the sperms to reach the ovary. The fertilized egg, however, is large, gets entrapped in the distal segment, causing ectopic pregnancy. In some cases, it is possible that ovum itself is at fault. Rapid development of trophoblast may favor the premature implantation in the fallopian tube. In contrast, delayed trophoblastic development may end up as a cervical pregnancy. Other causes such as appendicitis, pelvic endometriosis may involve the fallopian tube in adhesions, impair its mobility, or cause kinking. About 4% of pregnancies with IUCD are ectopic. The presence of IUCD is effective in preventing intrauterine pregnancy but not ectopic pregnancy. If proper asepsis is not followed at the time of insertion of IUCD, it can predispose to subsequent ectopic pregnancy. Progestogen containing IUCD and progesterone only contraceptive pills decrease the tubal peristalsis and thereby contribute to the occurrence of an ectopic pregnancy. Pathology of tubal pregnancy. It accounts for 90 to 95% all ectopic pregnancy. In a tubal pregnancy, the most frequent site is the implantation in the ampullary portion of the tube because plica are most numerous in this part and previous salpingitis is most likely to produce crypts here than elsewhere in the fallopian tube. Fimbrial portion is 6%, isthmus in 12%, interstitial portion of the tube in 2% is the incidence rate. Ovarian pregnancy. It is relatively uncommon site of ectopic seen in 1 to 2% of cases. However, because of the increased use of IUCDs, this is more common nowadays. Abdominal pregnancy. Primary abdominal pregnancy. This condition is extremely rare, where a pregnancy implants anywhere in the abdomen without any connection with the uterus or tube. It is possible that the ovum is implanted in the areas of ectopic decidua. Secondary abdominal pregnancy. Although rare, a secondary abdominal pregnancy results when a ruptured tubal pregnancy implants anywhere on the pelvic or abdominal viscera, and communication with the tube or uterus can be identified during the surgical management. In most cases, this condition gets diagnosed in second trimester on the basis of clinical examination and ultrasound. On rare occasions, an abdominal pregnancy continues till term when during laparotomy for suspected ruptured uterus, this condition comes to limelight. In most cases, fetus dies in abdomen or soon after laparotomy, profuse hemorrhage may occur at the surgery trying to remove the placenta implanted on the surface of bowel loops or some other structure. The woman may suffer mild abdominal pain, threatened abortion in early weeks, but pregnancy proceeds with abdominal discomfort throughout the pregnancy. At the term, the woman goes into spurious labor but fails to deliver spontaneously or with syntocin drip. Ultrasound or radiograph reveals an abnormal and high position of malformed or dead fetus outside the uterus. Interstitial pregnancy. It is a very rare form of ectopic gestation when the ovum is implanted in the interstitial portion of the tube. Usually, muscular septum intervenes between the gestational sac and the cavity of uterus. Interstitial pregnancy usually terminates by rupture into the peritoneal cavity during third month. Pregnancy in the accessory horns of uterus. Rarely, pregnancy may implant and grow in the accessory horn of uterus. The pregnancy may continue to 12 to 16 weeks. The condition may get diagnosed by routine ultrasound in early pregnancy. Patient may present rupture of the accessory horn with a resultant intraperitoneal bleeding. Coexisting intrauterine and ectopic pregnancy. This combination with intrauterine pregnancy is uncommon. However, in recent years, because of the widespread use of assisted reproductive techniques, this combination has become somewhat frequent. Combined uterine and extrauterine pregnancy is reported in 1 to 3% of successful IVF. In a spontaneous pregnancy, the incidence of combined pregnancy is very low. Symptoms, signs, and diagnosis. Accurate diagnosis of ectopic pregnancy is based on symptoms and clinical signs. The patient have normal signs and symptoms of normal pregnancy. However, soon symptoms such as pain in lower abdomen, spotting PV, and fainting spell sets in. One should consider the possibility of an ectopic pregnancy when a woman in early pregnancy presents with bizarre clinical features. The key to successful outcome is an early diagnosis of ectopic pregnancy. The clinical picture in ectopic gestation is related to pathological anatomy. A tubal rupture is an acute emergency associated with internal bleeding and shock. A tubal mole with peritubal and paratubal hematocele causes abdominal pain and irregular vaginal bleeding. This is less urgent and is called subacute or chronic ectopic gestation. Amenorrhea. About 75% patient present with a history of amenorrhea of less than 6 weeks duration. Rarely, ectopic pregnancy may rupture even before the patient misses her period. This is more likely to happen with the asemic tubal pregnancy. In a rare case of abdominal pregnancy, amenorrhea may proceed into the third trimester or even beyond 9 months. Duration of amenorrhea may be 3 to 4 months in cases of interstitial and corneal pregnancies. Pain, generally severe, is a consistent feature of ectopic pregnancy in 95% of the cases. Sudden acute pain in the abdomen is caused by tubal rupture resulting in hemoperitoneum. Occasionally, internal hemorrhage in the peritoneal cavity can irritate the undersurface of the diaphragm and phrenic nerve, leading to complaints of shoulder tip and epigastric pain. In a young patient brought in a condition of shock, complaining of the abdominal as well as shoulder pain, diagnosis of ectopic pregnancy is almost certain. In subacute variety, patient complains of vague abdominal pain, but signs of shock are absent. Hence, the diagnosis often goes missed. Vaginal bleeding. It is usually little in amount in the form of either dark altered blood or blood stained fluid. Bleeding is usually as a result of suppression of the decidua in the endometrial cavity. Rarely, it may be as a trickle from the fallopian tube. Under the hormonal effects, the endometrium shows residual changes. However, there is no chorionic villi. Acute retention of urine. In a subacute variety of ectopic pregnancy, the blood collects in pouch of Douglas to form a pelvic hematoma. This hematocele forms an irregular mass of differing consistency due to mixture of clot and blood and bulges forwards, displacing the cervix against the bladder neck, leading to retention of urine. Fever. If the pelvic hematocele gets secondarily infected, the patient develops slight fever. Physical signs. In ectopic pregnancy, acutely, a patient presents with sudden tubal rupture with acute intraperitoneal hemorrhage in the state of shock with marked pallor, tachycardia, and hypotension. The patient is cold, skin is clammy, temperature subnormal, the pulse thready with marked tachycardia. Blood pressure will be low. Breast changes of pregnancy may or may not be present depending upon the duration of pregnancy and parity. Abdomen is usually slightly distended, markedly tender with restricted movements. The distension is partly due to ileus of intestine. Due to presence of blood in the peritoneal cavity, rebound tenderness can be elicited in the lower abdomen. Rigidity may or may not be present. Signs of free fluid in the abdomen are present in case of profuse internal hemorrhage. Cervical movements during vaginal examination cause severe pain. Due to abdominal tenderness, it becomes difficult to make out the exact size of the uterus during bimanual examination. Bulge may be felt in the posterior fornix during pelvic examination in case of a hematocele. The clinical features of acute ectopic pregnancy are hemorrhagic shock, acute pain abdomen, amenorrhea, vaginal bleeding, abdomen tenderness. In subacute ectopic pregnancy or chronic cases, amenorrhea, abdominal pain, vaginal bleeding, retention of urine, abdominal mass, tenderness, ultrasound and beta HCG levels are diagnostic. In abdominal pregnancy, amenorrhea with colicky pain, post-maturity, failed induction, an ultrasound, abdominal fetal position, and a malformed or dead fetus is identified. Differential diagnosis of ectopic can be acute PID. It remains the most common differentiating diagnosis in case of suspected acute ectopic pregnancy. The absence of amenorrhea, fever, tachycardia, raised TLC, and the presence of bilateral tender masses in lateral fornices in a young patient following a recent sexual encounter should raise the possibility of acute PID. Corpus luteal hematoma simulates ectopic gestation both in the history and clinical findings. With a history of short period amenorrhea, pain, vaginal bleeding, and a tender mass with internal hemorrhage, it is difficult to rule out this condition. Ultrasound gives an identical finding in both conditions. However, a negative UPT, negative serum HCG go in favor of corpus luteal cyst. Perforated gastric or duodenal ulcer produce acute abdominal pain, but signs of internal hemorrhage are absent. Abdominal palpation reveals broad like rigidity, which is absent in ectopic pregnancy. Air may be seen under the diaphragm in gastric perforation. Perforated appendix, acute pancreatitis will demonstrate high fever, signs of peritonitis, raised TLC, amylase levels will help in making diagnosis of these conditions. Myocardial infarction has occasionally been considered when the patient complains of epigastric pain and collapses. Normal ECG and gynecological history will lead to accurate diagnosis. Subacute and chronic variety of ectopic pregnancy. In this, there may be some degree of constitutional disturbances as a result of localized intraperitoneal bleeding, but predominant feature are recurrent abdominal pain and vaginal bleeding. Retention of urine may occur due to pelvic hematoma. Pulse rate is raised in proportion to severity of the bleeding. Exceptional for the temperature to be It is exceptional for the temperature to be raised more than 99.5 degrees Fahrenheit. Differential diagnosis of chronic ectopic pregnancy are pyosalpinx. In acute pyosalping, patient runs high grade fever. Patient may complain of vaginal discharge. Signs of internal hemorrhage are absent. So the history of amenorrhea, though slight irregular vaginal bleeding may be present in pyosalpinx. Septic abortion. History of amenorrhea, pain, bleeding per vagina, with history of interference by trained or untrained person for termination of pregnancy helps in making diagnosis of septic abortion. Pelvic abscess. Hematocele, pelvic hematocele may be mistaken for a pelvic abscess, especially if the patient has fever. Cultosensititis reveals the nature of the swelling. Twisted ovarian cyst may cause acute abdominal pain and sometimes slight vaginal bleeding, but amenorrhea is absent, so are the signs of internal hemorrhage. Ruptured chocolate cyst. Although extremely rare condition, the rupture of chocolate cyst can mimic ectopic pregnancy. It causes shock and collapse with acute abdominal pain. The absence of amenorrhea, negative beta HCG and ultrasound help in making correct diagnosis. Uterine fibroid can also cause acute pain abdomen, a palpable abdominal mass if a serous fibroid undergoes torsion or if red degeneration develops in fibroid uterus. In such cases, history is more reliable than pelvic findings. Corpus luteal hematoma. It usually presents with a short period of amenorrhea, acute abdominal pain, vaginal bleeding, and rarely shock due to hemorrhage. Pelvic findings resemble that of ectopic pregnancy. A negative UPT, negative serum beta HCG, and carefully done TVS helps to make correct diagnosis. Diagnostic investigations include urinary or serum HCG. A positive UPT along with ultrasound findings and clinical suspicion helps in making diagnosis. However, a negative UPT cannot be relied to rule out ectopic pregnancy. Beta HCG is detected in serum 9 days at the level of 5 to 10 milli-international unit per ml and in urine 13 days after ovulation, around the time of implantation and before the missed period. The level doubles every 48 hours in normal pregnancy. However, in ectopic pregnancy, this doubling of beta HCG is absent. Rather, increase in beta HCG may be marginal or absent. Therefore, in case of doubt and if the condition of the woman remains stable, serial study and doubling time are useful. If the level does not rise or rises by less than 66% from previous reading, ectopic pregnancy or missed abortion should be suspected. When beta HCG level is more than 6500 milli-international units per liter, intrauterine sac is visible on abdominal ultrasound. Similarly, with a serum HCG value of 1500 milli-international units per liter, an intrauterine gestation sac should be visible on TVS. Investigations are pregnancy test, serum beta HCG level repeated every 2 days, ultrasound or MRI, cultosynthesis, and laparoscopy. Failure of rise in HCG by 2 folds in 48 hours is suggestive of ectopic pregnancy. The doubling rate of beta HCG is slow, with less than 66% increase over 48 hours. Ultrasound. It has come to occupy the place of most important investigation in case of ectopic pregnancy. The uterine cavity appears empty and a mass can be seen in region of adnexal. A gestational sac in the adnexa is however identified only in 5 to 15% of cases of early ectopic pregnancy. Beta HCG in the urine and serum, an empty uterine cavity, adnexal mass with free fluid in the peritoneal cavity is pathognomic of ectopic pregnancy. The ultrasound findings at the time may resemble that of PID and endometriosis. The main advantage of transvaginal sonogram lies in making early diagnosis of intrauterine pregnancy. At 5 weeks of gestation, when beta HCG reaches 1000 milli-international unit per liter, a gestational sac with yolk sac is visible. In ectopic pregnancy, a pseudo sac or empty sac without yolk is formed by decidual thickening and is centrally placed in the uterus. Other ultrasonic features are blob sign, Bagel sign. A blood clot with trophoblastic tissue is known as blob sign. An empty gestational sac in the fallopian tube is known as Bagel sign. Corpus luteal hemorrhage shows spider web-like contents with hemorrhagic areas. Doppler ultrasound reveals increased vascularity and a sign called fireball appearance has been described in case of ectopic pregnancy. TVS detects uterine gestational sac 1 week earlier than transabdominal probe and gives clearer image because of its proximity to the pelvic organs. Pregnancy can be detected by TVS approximately 14 days after pregnancy detection by serum HCG at 1000 milli-international units per level. Caldosensititis or aspiration of the pouch of Douglas. In past, aspiration from pouch of Douglas by placing patient in lithotomy position was commonly done to diagnose ectopic pregnancy. Aspiration of 2 to 5 ml of non-clotting blood was taken as diagnostic of ectopic pregnancy. A needle with its tip at wrong place or the presence of adhesions in pouch of Douglas could lead to false negative result. Other hormone studies include placental proteins, especially PP14, are reduced in ectopic pregnancy and their diagnostic value appears to be useful. SP1, PAPA1 appear late after 6 weeks of gestation, therefore their value in early diagnosis of ectopic pregnancy remains doubtful. Normal progesterone level in early pregnancy is 25 nanogram per ml. Less than 2 nanogram per ml is seen in ectopic pregnancy, but its use in clinical practice is limited. Laparoscopy. When ectopic pregnancy is suspected but diagnosis is in doubt, in spite of equivocal findings on hormonal tests, ultrasound, one should proceed with laparoscopic visualization of the pelvic organ. Treatment. For long, laparotomy is the only management for ectopic. It was life-saving measure for acute tubal rupture with massive intraperitoneal hemorrhage. However, now there are options such as expectant management, medical management and conservative surgical treatment in early diagnosed case of ectopic pregnancy who are hemodynamically stable. Medical management include methotrexate therapy. Methotrexate is a folate antagonist that inactivates dihydrofolate reductase enzyme, leading to fall in tetrahydrofolate. A single dose of methotrexate therapy given in dose of 50 mg per meter square IM can help in slow decline of beta HCG and ultimate dissolution of ectopic pregnancy. This form of therapy has 90% success rate, although 4% may require one or more dose of methotrexate. Recognized by slow decline in HCG or failure of treatment, which is defined as failure of HCG to fall beyond 15% in the last 4 to 7 days. Higher failure rate has been reported in women with previous ectopic. About 80% conceive, but repeat ectopic pregnancy is reported in 15% of the cases. Injection methotrexate 25 to 50 mg injected in gestational sac under ultrasound or laparoscopic guidance has also shown similar success rate. Prerequisites are the woman should be hemodynamically stable, ectopic pregnancy should be unruptured, serum beta HCG should not exceed 6500 to 1000 milli international unit per ml. Size of gestational sac should not exceed 3 to 5 cm in its longest diameter. Fetal cardiac activity should be absent. Patient should be willing to come for follow-up. There should be no contraindication to methotrexate such as liver disease or anemia. Patient should be desirous of future fertility. Hemoglobin WBC liver function should be normal. Side effects of methotrexate are anemia, leukopenia, agranulocytosis, thrombocytopenia, hepatorenal toxicity, nausea, vomiting, gastric hemorrhage and alopecia. Contraindications are abnormal serum creatinine level, LFT and liver enzymes are elevated, low hemoglobin or platelet count, pre-existing blood dyscrasia, acute pulmonary disease, peptic ulcer, immunodeficiency disease, breastfeeding, known drug allergy or sensitivity in the presence of drug allergy, gestational sac greater than 3.5 cm, presence of fetal cardiac activity, cervical caesarean scar or interstitial pregnancy. Other surgically administered medical drugs are mifepristone, prostaglandin, 20% KCl solution, glucose solution. All of these are injected into the gestational sac under ultrasound or laparoscopic control. Of these, methotrexate has been proved the most effective. Post-medical management consists avoiding use of alcohol, avoid pregnancy until ectopic pregnancy resolves and serum HCG becomes undetectable. Surgical treatment include all patients with acute ectopic should be operated upon earliest once the diagnosis is made. It consists of open laparotomy, identifying the affected tube, clamping the mesosalpinx, performing salpingectomy. The pedicles are transfixed, the blood present in the abdomen and pelvis is removed. Before removing the affected tube, always look for contralateral fallopian tube. This is important in case the patient has infertility and is desirous to preserve fallopian tube for subsequent pregnancy. It is important to inspect the contralateral tube. Rarely, bilateral tubal pregnancy may be encountered. or the other fallopian tube is diseased or damaged, condition of tube needs to be assessed to check the prognosis of future pregnancy. Types of surgery on the fallopian tube. Salpingectomy, if the gestational sac is greater than 4 cm, most of the tube is damaged and the other tube is healthy. Partial salpingectomy, if more than 6 cm of the tube can be preserved. Later, tuber anastomosis can be performed. Salpingostomy, antimesenteric border is incised, conceptus is removed, hemostasis is secured and the wound is left open for secondary healing. Pregnancy rate is better than with salpingotomy. Repeat ectopic pregnancy is low. The wound is closed with fine visceral sutures. Milking of the tube is possible with fembryal pregnancy, but because of the risk of persistent intratubal bleeding and persistent trophoblastic tissue and increased risk of recurrent ectopic, this technique is not used now. Conservative tubal surgery is justifiable only if the contralateral tube has already been removed or are deceased, because this type of surgery exposes the woman to recurrent ectopic pregnancy. 50% of women undergoing conservative conceive and have uterine pregnancy. Expectant treatment in case of unruptured pregnancy are follow-up with serial HCG levels and ultrasound. It is applicable only if gestational sac is less than 2 cm, HCG levels are not very high, and the absence of hemoperitoneum. In most cases, pregnancy is resolved without any surgical or medical treatment. However, due to uncertainty and prolonged follow-up, it is not practical. Ovarian pregnancy. Spiegelberg criteria to diagnose ovarian pregnancy is: pregnancy is in close relation to the ovary, fallopian tube on the affected side is normal, mass is attached to the uterus by ovarian ligament, histological chorionic tissue is in intimate contact with the ovarian tissues. Flow chart suggesting features of ectopic pregnancy. First, UPT is done if it is weakly positive, missed abortion or early ectopic or early uterine pregnancy is suspected. Repeat serum beta HCG after 48 hours plus pelvic ultrasound. If the titer is falling, irregular gestational sac is present, then it's a case of blighted ovum or missed abortion. If the titer is rising but less than 66%, consider ectopic pregnancy. Repeat the ultrasound and diagnostic lab can be done. If the scan shows normal features, false positive pregnancy test or too early scan, repeat beta HCG and scan. Intrauterine pregnancy, repeat ultrasound in IVF pregnancy to exclude concomitant ectopic pregnancy. If the sac is empty, then the scan may be too early, so repeat the scan plus serum beta HCG levels. It may be case of blighted ovum, so repeat the scan and beta HCG values. If the adnexal mass is present and empty uterus, then go for laparoscopy or minimally requisite surgery. If the titers are rising and gestation is in uterus, gestational sac is in uterus, then it is a normal pregnancy. If the UPT is positive, maternal serum beta HCG levels are greater than 1000 international units per liter, then do an ultrasound of pelvis and follow accordingly. If sonography shows adnexal mass and if the mass is less than 3 cm, medical management can be tried: methotrexate local or systemic, prostaglandin F2 alpha, mifepristone, KCl, hyperosmolar glucose. Follow up with HCG. It can be successful, or if the HCG is rising, plateau or bleeding is persistent, then go for laparotomy. If the adnexal mass is greater 3 to 5 cm, go for laparoscopy, salpingectomy, milking fembryal end, salpingostomy, resection, study of the opposite tube. If the adnexal mass is greater than 5 cm or free fluid is present, go for laparotomy, salpingectomy, salpingo-oophorectomy, study the opposite tube. Cervical pregnancy. It's extremely rare. Incidence is 1 in 1000 pregnancies. It can be diagnosed by ultrasound using Rubin's criteria. There should be no fetal tissue in the uterine cavity. There should be cervical glands opposite the placental tissue. The sac and the fetal tissue present in the cervical canal should be below the level of reflection of peritoneum in the pelvis. Ultrasound criteria are as follows: empty uterus, balloon cervix, gestational sac and fetal tissue below the level of internal os. Internal os is closed, blood flow in the cervix is increased, absent of sliding sign. The pressure over the cervix causes sliding down of the gestational sac and miscarriage, whereas cervical pregnancy remains static because it is attached to the cervix. Treatment include: because of risk of profuse bleeding during any surgical procedure, it consists of ligating the uterine vessel vaginally, suction evacuation, tamponade, inserting a Foley's catheter in the cervical canal for 24 hours. In case of profuse hemorrhage, occasional hysterectomy may be needed. Hysteroscopic resection of the cervical pregnancy using resectoscope has been described by Ash and Fenrel. Unlike in tubal pregnancy, IM methotrexate may have to be repeated weekly until the beta HCG levels disappears.